so narrow-complex tachycardias. Before we start, I really have to ask you to be interactive because it's really essential with the EKG lectures. Okay? All right. Good. So briefly, three main things that we want to achieve today with the lecture. You have to I mean, maybe some of you already are pretty good with arrhythmias and know how to do it, but the essential thing is to learn how to build a differential diagnosis. Then we're going to go over some common arrhythmias that present as narrow complex tachycardia, and then we're going to practice some cases that should cover most of the clinical scenarios. And we'll touch a little bit about management, but by now in residency, you've all experienced this. All right. So I think, whenever you're faced with the narrow complex tachycardia, one thing that I want to tell you to keep in mind, and as most of you who did EP rotations know, there's a lot of situations when it's just unclear based on the surface EKG what is the exact diagnosis, and it requires further electrophysiologic study to determine the mechanism of arrhythmia. So don't be frustrated if you cannot make the diagnosis from the surface EKG. It's a very common thing for that to happen. You just don't have enough information. But one really helpful thing is to divide these arrhythmias into short RP tachycardia and long RP tachycardia. And that's simply by, if measuring the distance from the QRS to the P wave. If a P wave extends, more than halfway to that interval between two RR waves, that's your long RP. And if it's obviously shorter than half, it's going to go into this bucket of short RP tachycardias. So this is one way of looking at. So this classification only pertains basically to narrow complex tachycardias that have a relationship of P's to QRS complexes 1 to 1. And I'll show you more diagrams and it will be easier for you to understand. But the list, a laundry list now, which we'll go through each of these and it's going to be much clearer for you later. But short RP tachycardias, essentially possibilities, are AV and RT, AVRT, and amongst those, there are certain subtypes, but just remember for this now. Junctional tachycardia, then you can have atrial tachycardia that has a long PR, right? It's going to have short RP, but then the next, R is going to create this long PR interval. And you have sinus tachycardia in someone who has maybe first degree AV block and has a long PR interval. And then you systematically go, so you have to have this list in your mind, and then you go systematically through other things and try to figure out which one it is. Then long RP tachycardia can be just regular sinus tachycardia, right? You have a P wave and it's right in front of the QRS, and then atrial tachycardia, then atypical AV and RT. And you can have also a rarer form of AVRT. And I also wanted to point out that sometimes in the literature you're going to see this term BJRT. So just not to get confused, when you read, that's really essentially an AVRT that has a retrograde pathway that is really slowly conducted. Again, remember, this is only pertaining to narrow complex tachycardias that have a relationship of P wave to QRS 1 to 1. So now what you need to understand, we went through all these lists, and probably some of you who are more interested in cardiology maybe know all these arrhythmias. Some of you who are not interested in cardiology maybe do not know. So I think we should go over how mechanistically and anatomically, these arrhythmias look like. And this photo is really it needs to be essential for you to understand later how the genesis of the actual EKG is, why the EKG appears the way it appears. So in electrophysiology, most of the arrhythmias are re-entry arrhythmias, meaning they have a certain circuit, and it's all about the circuit. So you have to understand, for any arrhythmia, you have to understand what are the components of the circuit. And then that will make you understand how the EKG looks like, and it will also you'll understand how to break that circuit and end the arrhythmia, right? So in your atrial flutter, your circuit is really, and this is for for typical flutter and like 80% of flutters, its circuit is in the right atrium, in around this narrow tissue between the tricuspid valve, in the vena cava. So essentially the cavo tricuspid isthmus, right? It's part of the circle, and then you have this essentially circle in the right atrium that further depolarizes the atria and the ventricles. That's your flutter, right? Then in focal atrial tachycardia, you have this star here, right? It tells you, okay, this particular tachycardia originates from left side, and even though it's kind of intuitively you think that the atrial tachycardia is just ectopic activity that is not a circuit. Well, actually, there's just a micro, small circuit that generates these like depolarizations of atria and forms the P waves on the EKG that are not as normal sinus, and that's your atrial tachycardia. So it involves so the circuit involves a certain part of the atria, right? In the AV-NRT, your circuit is within the AV node. So the main circuit is involving the slow and fast pathway of the AV node. And then everything else just gets depolarized as a consequence of this signal kind of like spreading out of that circuit, right? So that's your AV-NRT. Now in your orthodromic AV-RT, you have your circuit part of your circuit is a accessory pathway. So only people with accessory pathway are going to be able to have these arrhythmias. And also these accessory pathway, which is depicted by this little yellow thing here, has to have a property of retrograde conduction. So if the pathway is not able to retrograde conduct, you will never have orthodromic AVRT. You might have antidromic or some other arrhythmias, but this one you will not have. And this circuit involves the AV node, right? It goes down the ventricles, goes up the ventricles, and then up the accessory pathway, and then atria, that's your orthodromic AVRT. And then in antidromic AVRT is the same thing, just in the opposite direction, but we'll not talk about this because it manifests as a wide complex arrhythmia. So now this photo, this diagram from one of the textbooks, like I would urge you not to like take a photo of it or like however you want to save it, because I want you guys, whoever is going to later volunteer or whoever I'm going to pick on, I want you to go to this algorithm so you reinforce it in your head and then see how can you come to the diagnosis with just excluding things, going really like in a kind of recipe manner, and really it will make you realize that narrow complex tachycardias are pretty simple. But the main thing here, the distinction between irregular and regular is important, because irregular has a very limited amount of differential diagnosis, such as multifocal atrial tachycardia and AFib, or sinus rhythm with APCs. Flutter with a variable block. And then remember, and you always in every textbook, the obsessive question in analyzing arrhythmia, where is the P wave? What is the relationship? It's really because of this. You see the regular narrow complex tachycardia, really the dichotomy is important in between, is there a same number of P's and QRSs, or there are more P's than QRSs? Because as you see, you narrow down your differential diagnosis significantly if you notice that there are more P's than QRS. So then automatically your brain is much less overwhelmed, and you can focus your further in seeking of clues that can confirm one of these diagnoses. And then remember what I told you, that when we went to all the short RP and long RP, only in the situation of the equal number of P's to QRS. And then you have a nice breakdown of short RP and longer RP that I already mentioned to you. With one little, also very useful dichotomy here is that if these P waves that come right after the QRS, a very, very short time frame of less than 90 milliseconds, most of the cases really that's AV-NRT. And if you remember, really the reason for that, if we go to mechanistically, speaking, is because the circuit is so small, and after this circuit depolarizes the ventricles really immediately fast after that you have a retrograde depolarization of the atria. So in this situation, you will have much shorter RP interval compared to, for example, this situation. So this distinction can really help you, make the diagnosis of AVNRT. And then this is the other thing that I want you to take note of, and then we'll go through this also as we practice cases. Every narrow complex tachycardia that you encounter on the floors, or if you're in the unit and patient is stable, you really should just do adenosine or vagal maneuver. And one thing that I want to stress out is that classically AVNRT, we're always talking about how that's usually when you break the arrhythmias AVNRT. Make a note that it's not always AVNRT, because remember, AVRT, let's go back to mechanistically speaking, has the integral part of circuit is AV node. So if you block the AV node, you're going to block this entire circuit. And in SA node re-enter tachycardia can also stop with adenosine, and very rarely, that's why it's in parentheses, it's focal atrial tachycardia. And then these other ones, you're just going to have the slowing, because the AV node gets slowed down, but it's not an integral part of the circuit. So you will just see what is the underlying atrial activity, and that's how you will then focus your diagnostic assessment further. Okay, now let's speed up a little bit. So there are some really quick clues that are just epidemiologic and clinicals. When you see a patient with narrow complex tachycardia, most common is really AVNRT. Then there's this kind of age of onset lower for AVRT, assuming because there's accessory pathway present since ever since birth. And some I personally don't think these are as useful. Maybe just remembering that AVNRT is really the most common. Again, termination of tachycardia by vagal maneuver, which we suggested already. Again, AVNRT or AVRT most commonly. And then presentation with syncope actually with SVT is not really common if you have a normal heart. But if you have an underlying significant structural cardiac abnormality, then SVT can actually cause you to have syncope. So then, many times you've seen this, right? This kind of Cannon waves, and they're mentioned both in heart block, they're mentioned in SVT. I wanted to just, this is something that you'll observe on a patient who has SVT, but why is it useful? Because compared to heart block, you see that in SVT, essentially every beat you have a Cannon wave, especially in AVNRT. Once your atrium contracts against the closed tricuspid valve, versus in complete block, just so you don't confuse those two conditions, is only occasionally the Cannon wave is going to happen when really the timing is appropriate for the atrium to contract against the closed tricuspid. And this you cannot neglect to do when you're analyzing your patient that you're encountering with whatever clinical setting, is other sources of tracing. Review telemetry. You have to find the onset, you have to find the termination of arrhythmia. Understand the graphic trend of heart rate. Was it abrupt? Was it gradual increase in heart rate, etc. Then review the data for any implanted device that is present. You have to join all these data in order to fully characterize arrhythmia. And there's one interesting trick where maybe if you rotate on EP service, you might see this post-surgery patient who have epicardial wires. So if you attach the epicardial wires that are on the atria, you can actually see the atrial signal and easily diagnose it. So now let's go over some common arrhythmias that present as narrow complex. Who's gonna do this one? Let's see. What am I gonna?
I can start, Luka.
All right, excellent. Let's go. And
so
let's follow the little algorithm that we've given in the beginning. And if you don't have a note of it, I'll just remind you. First of all, if this is regular or irregular.
Thank you. So this seems regular.
Okay. So now remember, in that little algorithm of ours, now the question is, Do you see any P waves? And if you do, is this one-to-one P to QRS relationship, or is it a more P's than QRS?
The only thing that I can see potentially as a P wave is in the long lead V1.
Okay.
In the later beats.
You mean this, right?
Yeah. It's like on top of the T wave in some beats.
Okay. So so whenever you're looking for P waves, you know, I think V1 is a great lead also, and you should also, and we'll go over that later and be also clear why is that important, but you focus your eyes on inferior leads, especially lead 2, and V1. So V1 here is tricky, I agree. But if you look at the lead 2, you see these little negative deflections that really are not, yeah,
well.
it's really not like a QRS complex type. Again, you have to just train your eyes a little bit. And then in AVF, you see now if you started off thinking, maybe this is a retrograde P wave, you go down this because this is all the same timing, right? And then you see there's again another notch here, which would be unusual in a QRS that is pretty narrow. If someone has a wide QRS, then you can see all sort of notching. But this is a narrow QRS, pretty narrow. So you should not have these like weird notching that extend more than 40 milliseconds later. And then if you go to AVF now, knowing that you have suspicious, repetitive deflections here that look like retrograde P waves, it just kind of confirms that there are retrograde P waves and inferior leads. So now that we established that, now what's the relationship now? Is it this P to QRS 1-to-1? Is it more P waves than QRS?
I would say 1-to-1.
Okay. So now, since it's 1-to-1, you go down your little algorithm, right? And now you measure how soon does this P wave come after the R wave. And it's essentially like a little bit above one small box, meaning maybe like 60-ish milliseconds at most. So it means it's less than 90 milliseconds, right?
Yeah.
And if you just don't know anything, don't know anything about arrhythmias, and you follow this, and you will reach in your algorithm to the diagnosis of AVNRT as a most likely possibility. And that's it. That's the diagnosis. It's AVNRT. And remember, it's because the circuit is an AV node. And now we will go over that. Why does the EKG appears the way it appears? So let's focus your eyes now on the upper left diagram here. So you have your AV node. This here is going to be your atrium, and then ventricles are somewhere down here. You have the His spot. So really the prerequisite for someone to have AVNRT is to have this property of two pathways in the AV node. One is the fast pathway and one is the slow pathway. And this is now a normal sinus rhythm. And you have EKG here, what happens in normal sinus rhythm. So you have your sinus node, it fires, the signal goes down both pathways. You have your P wave because your atria is depolarized in a normal way. What happens here is that because this pathway is slow, so the impulse goes slowly. By the time impulse comes here, it really hits the refractory period of this fast pathway, and it just basically terminates. So in your surface EKG, you see a normal EKG. That's it. Your P wave, QRS is a consequence of this going through his bundle and further. But so remember, this pathway's fast pathway, it conducts very fast, but has a long refractory period. In slow pathway conducts slow, but has a short refractory period. So let's say you have a random APC, right? this APC coming from somewhere else, and it's timed differently. It's not like timed at, when sinus node is supposed to hit. So it's timed in a way that this APC starts depolarizing the atria. And so now let's focus our eyes here, this upper right. So we have step one, right? The signal starts, but hits the refractory period here because of the, remember what we said, fast pathway. It conducts very fast, but it has a long refractory period. So it hits the refractory period there. And now the only way, so let's go to number two, the only way this is going to conduct down can be the slow pathway. So slow pathway maybe it can be in the refractory period also, but since we know that the pathway has a short refractory period, it's recovered. So now you have the AV node has been kind of invaded by this signal, but only through slow pathway. And the impulse is going. But now, since this area has had a long time to recover, this impulse now invaded into the fast pathway back because it's not in a refractory period anymore. Goes back now, goes back to the atria. This is your step 3, and causes that retrograde P wave that you always see. So what happens here now? Let's go again. So you have APC, depolarize the atria. That's your P wave. You have now slow pathway conduction. That's your long PR interval. Regular QRS because it went down, but at the same time you have a little bit of impulse going up and causes this echo peak. So now if this thing happens again, which happens in AVNRT, you basically have AVNRT. And this is your third diagram here, when you have this repetitive situation where every time this goes back, depolarizes, makes a retrograde. And then the treatment is really, you modify this, break the circuit, right? Remember, every arrhythmia is about the circuit. What are the components? So if you ablate the slow pathway, this, situation should not happen. So now you understand why, how is the retrograde P wave in AVNRT generated, and you also understand now why is that RP so short, because this is only this like small reentry circuit here and then retrograde conduction. So that's essentially our AVNRT example. So let's talk about this this EKG now. Who wants to do this one? Maybe Joseph. He excelled on his EP rotation. I don't know now. He's very, very silent.
Maybe he
didn't hear.
Joe, can you try it?
No.
You can try again. That's other future cardiology fellows.
Anyone else? I mean, it's like really just, I'm going to guide you through this. It's like not a test.
Nero, come on.
I can try.
Yeah. So let's just follow the algorithm. That's all. That's all. Recipe.
Okay. So it's narrow complex.
Okay.
It looks regular.
Okay.
Okay.
So now the P waves, the crucial thing.
Now the P waves. It looks to me like it's 1-to-1.
Okay.
Yeah. And okay, so now then we're looking for the RP interval. And it seems, okay, so the P waves that I'm seeing, they just seem to be, so I'm looking at lead 2.
Okay.
So
this is the P wave.
Yeah, the negative P waves, right?
Negative. Okay. So now you immediately know that your depolarization is going from
Opposite
low, kind of retrograde,
yeah.
from low atrium to high.
Okay. So the RP is actually greater than the PR interval. So this would be a long RP.
Longer. Okay. So now if we go to our little diagram and we have our long RP tachycardia. So what is your differential diagnosis?
So if I'm just looking at the algorithm, there are 5 differentials, but then we can I think we can rule out sinus tachycardia just because there's retrograde P waves. I think the same would go for
So you can also rule out the sinus node re-entry.
re-entry. Yeah.
It's P wave doesn't make sense to be like.
So we would have focal atrial tachycardia. It's possible AVRT and atypical AVNRT.
So now, based on those three, you kind of know. So you know that atypical AVNRT is the least common of these, but again, you don't know at this point.
Yeah.
So, but now you have three differential diagnoses, and now next thing what you can do is you can give adenosine to this person. So if you give adenosine, which then diagnoses are more likely to?
So if the patient responds to, do you want to do a Dennis, or a vagal maneuver?
Vagal doesn't matter.
Yeah, and they respond, then it's likely it's AVRT or AVNRT.
Correct. So then you're really left with those two diagnoses. And to be honest, like I don't think you can tell fully. You have to do EP study. But if you're just gonna go by atypical AVNRT is very rare, then I'm gonna be like, okay, based on the surface EKG and epidemiologic, characteristics, are most likely diagnosis is AVRT. But again, if this is a recurring issue in this patient, you will have to do an EP study, and you will have to do, set of maneuvers that will, then fully differentiate, where is their circuit. But this just illustrates how, you started off with 5 diagnoses, and you easily discarded 2, and then you gave adenosine, you kind of discarded 1 more diagnosis, and you're left with 2 only, which, in acute and short-term management doesn't make much difference. And I'll just now go over the mechanism of why the EKG looks the way it looks like. So again, it's a very similar, if you understand this concept, that is very similar like AVNRT, you will essentially understand most of the arrhythmias. So let's say someone has accessory pathway. Look at the first picture, right? So this green little box is the accessory pathway, and it shows you here how when the signal starts from the SA node, goes down the accessory pathway, this delta wave is really a consequence of this earlier depolarization here before even signal goes through the so then, what can happen again is that, let's say you have an APC, your little star, and then this star is your P wave, kind of like a weird P wave that is consequence of the APC. And then the APC gets, blocked in the accessory pathway, goes down the regular AV node in QRS. So now, by the time, because there was a block here, by the time the signal came up, your accessory pathway is now, not in refractory period anymore. So your signal, your impulse, invaded your accessory pathway and now conducted backwards and started the circuit. So it's the exact same concept like slow and fast pathway in the AV node. It's just that this circuit here, instead of being just the AV node, is this whole thing. And then the cycle just perpetuates. That automatically, you understand the treatment. If you ablate any part of this circuit, you're gonna get rid of the arrhythmia. You're certainly not gonna ablate the AV node. You're not gonna randomly chase things in the ventricle. So you're gonna ablate the accessory pathway. This we already went. And then again, one thing, one of the clinical clues that AVRT is a diagnosis is, let's say you see an narrow complex tachycardia with a long RP involved, and then you look back in old EKGs and see if you find evidence of pre-excitation. And if there is evidence of pre-excitation, like WPW, then you say, yeah, well, most likely diagnosis AVRT. But there are certain pathways that are concealed that never they never conduct antegrade. So these patients will not have a delta wave or pre-excitation when they're in sinus rhythm, but they can still have AVRT. Just like a point that absence of pre-excitation in sinus rhythm does not exclude the diagnosis of AVRT. All right, who's gonna do this one? Any volunteer? Subrat is not muted.
Yeah, so that is unmuted.
He's getting ready.
Oh, okay. I'll try. I think Petra, I will need your help. Definitely, sorry, Luka, I will need your help for that. I see that it's fairly regular, I would think.
Okay, so we got a regular.
A narrow complex.
Okay.
And we see that there are like two P waves. Looks like the first one I can see on the lead 2 is it's superimposed on the T wave.
Okay, so you
And
have
second-
so now just stop there. You immediately basically came to now a certain differential. So now you have regular arrhythmia, narrow complex. There are more P's than QRS. So what's your differential?
It could be either like atrial flutter,
Okay.
or there's I think one more. I have to look at the chart.
Yeah, just look, and I'll tell you, it's focal atrial tachycardia. So those two are only possibilities. So it's very easy, right? So initially, when you looked at this EKG, you were thinking probably, oh my gosh, how am I going to like interpret this now, et cetera, et cetera. But now you just have two things to look at. So how are you going to differentiate between focal atrial tachycardia and atrial flutter? And again, sometimes it's hard and you might not be able to, but let's say it now.
So normally for like atrial flutter, we look for the leads 2, 3 AVF to see for like a flutter wave based on which we think about if it's a typical atrial flutter or atypical atrial flutter.
Yeah.
So I see that in the 2, 3 AVF, the P waves are positive. I'm not really sure if there's a way to differentiate between that and the like the focal atrial tachycardia.
Yes. So basically, like I think one thing that suggests, and again, you can have very atypical forms of flutter and atrial tachycardia, sometimes impossible to differentiate. But in just basic sense, your classic flutter circuit will generate an atrial rate of 250 to 350, around 300 usually. While atrial tachycardias are a little bit on the slower side. So if you look at this one, let's say here, or any of these leads, so this is around like 200-ish or a little bit faster at 200. So based on that rate, I would say, more likely atrial tachycardia. And then if we say like, okay, this is not going to be an atypical flutter, based on morphology, you have a nice isoelectric line between, two P waves, which kind of like goes against flutter. And then you have kind of like a clear, different type of morphology. You have positive, 2, 3 and AVF, negative V1, this really distinct P wave, distinct morphology. So kind of tells you more of an organized activity, a little more organized than flutter. Because in atrial tachycardia, what happens, you either have a triggered activity or you have a micro-reentry circuit that then depolarizes the whole atria to normal tissue, other tissue. So you get a little bit of more formed P wave compared to flutter that really the circuit is pretty big in the entire atrium. So it kind of abnormally depolarizes a majority of the atrium. So that's your atrial tachycardia. So now, so in order to understand like one concept that I wanted to introduce to you guys, when you look at the P wave in atrial tachycardia, in a very simple manner, you can now you will be able to differentiate, is this, an atrial tachycardia coming from my septum, from like lateral sides? Is it from retrograde? Is it coming from the higher atrium? So one thing that you have to know is the normal atrial depolarization, right? So in normal situation, you have your, starts from the sinus node, goes right atrium, goes to the left atrium, and then your overall vector, if you look in the lower right corner, it's kind of like this. This is your vector of atrial depolarization. And what happens with this is you have in sinus rhythm, you have a classic morphology in your lead 2, it's predominantly positive because of this vector. And in your lead V1, that's why I always tell you, focus your eyes on the inferior leads, especially lead 2 and lead V1 when you're looking for P waves, because that's where, you get the most, most information. In your V1, you're going to have first a positive, second negative deflection because of this sequence of depolarization and the location of the V1 electron. Now, once you know this, now in atrial tachycardia, it's all about analysis of this, vector of the P wave. So now these photos look a little bit archaic, but the textbook is not as old as the scan is pretty bad. But essentially, so now how are you going to analyze those P waves in atrial tachycardia? There's a very, very simple way to do this. So let's say you have here, if you look at my pointer here, there's a little black kind of a star here that says that this particular atrial tachycardia is initiated from septal region and low. So now knowing how your leads, look like, you're going to focus your eyes on your lead 2. You're going to focus your eyes on their direction in your inferior leads. And once you see that, P waves are negative in inferior leads, that automatically tells you there's a low to high activation. And then the next thing that you want to look at, so number 1 is, right, is it positive or negative deflection in the inferior leads where you're expected to see positive? And the second thing, is it very narrow P wave or is it a wider P wave? That will tell you whether a arrhythmia originates more towards the septum, if it's narrow, because if you have septal origin, it's gonna depolarize both atria at the same time because it starts from here, so it goes both sides kind of simultaneously. So you're gonna have a narrow P wave, or if it's like comes lateral, it's gonna have a sequential depolarization of one and then the next atrium. So the P wave is going to be a little wider. So to summarize, when you're analyzing, when you have reached your conclusion that this might be a atrial tachycardia, don't stop there. You can analyze further, and you can say, okay, I have inferior leads. Do I have low to high activation or high to low activation? And then the next thing is width of the P wave, and that tells you whether you have septal to lateral or lateral one or the other side activation towards the other side. So then all the examples of this would be, for example, so here you have in your left side, left upper pulmonary vein focus. And then if you analyze all your leads here, you look at your inferior leads, you have a positive P wave, so you know that's a high to low activation. And then you analyze, the width, and it's kind of like, definitely not very, very narrow, like this one. You see, this one is like pretty narrow, so it's kind of like a lateral activation essentially. And then from the right side, it's going to be very, very similar like your sinus. So you're going to have a positive P wave in inferior leads, and it's going to vary, in terms of width, whether it's a little bit more towards septum or a little bit more towards the atrium. So now if you go back to this EKG and you start analyzing, you see that you have 2, 3, and AVF are pretty positive P waves. So you know that you have a high to low activation. So this is not something coming from like coronary maybe sinus os or somewhere around AV node, something coming from high up, and based on the width, it's probably not in the septal region. Again, there are many more like nuances to this analysis, but this is just the basic approach, just to get a sense of your atrial activation. All right, and let's go over this one quickly. Who wants to do this one?
Andrew? I see Fatma also unmuted herself. Fatma, you want to give
Okay.
it? Yeah.
Yes, I can go through this. So this is a narrow complex tachycardia. I can see atrial flutter waves on the inferior leads, and
Perfect. I mean, so let's just go step by step just to reinforce the step analysis. So let's first start, is it irregular or irregular?
it's irregular, narrow
Irregular.
complex.
Okay, so irregular, what is your differential diagnosis?
Irregular, it's whether AFib or atrial flutter with AV block,
Variable AV block.
or variable block, or
You can have multifocal atrial tachycardia.
multifocal. Yes.
Yeah, and you can have sinus rhythm with just PAC.
Yeah.
So as you pointed out already, it looks like the P waves are abnormal, so definitely not sinus, right? Is it multifocal atrial tachycardia?
No.
So not, because you have, whatever you have these notches on your V1, whether they're flutter waves or atrial tach, it doesn't look like they're in different morphologies. So you excluded that. It's not AFib, right? Because you have organized atrial activity. Essentially you are left with either atrial tachycardia or atrial flutter with variable block. And then once, as you said, you saw flutter waves because you saw the sawtooth pattern, which is really like a typical for a flutter. So you have reached the diagnosis of the flutter wave. That's it. That's all it is. It's very, very simple. So let's go over genesis of this. What happens here is in your typical flutter, remember this is your re-entry circuit. And essentially this arrow shows you that during where the impulse goes through this region, cavo-tricuspid isthmus, it kind of slows down a little bit. And that slowing down is actually giving you that slurred pattern, which further generates your sawtooth pattern on the EKG. And the only thing really to remember, it's flutters and atrial tachycardias are really kind of on the spectrum of these arrhythmic disorders. If flutter can, in some electrophysiologic textbooks, it's actually referred to as a atrial tachycardia, just with a macro reentry circuit. So just to understand, it's actually really like a spectrum of conditions. And I just wanted you to know that the reason really why the sawtooth pattern is formed, it's really because of this slowing of the impulse during a certain part of the circuit in the right atrium. And then when the fast depolarization happens, you have your negative or positive deflection that further determines whether you're dealing with a counterclockwise or clockwise flutters. And these flutters are really called typical flutter, and they're in a vast majority of flutters. And in a other rare form, this is a particular example of just a typical flutter, and you have negative P waves here, positive in V1, and you have a rate around 300, so it all fits, and a little bit of irregularity here, so it fits all of your criteria. And then further, just very rarely, you have these, whenever you have a patient, you're admitting a patient, you see history of a bunch of things that have been done on the atria, whether percutaneous or open surgical, then you can expect these atypical circuits forming around the scars, pulmonary veins, etc. So, but that's rare. And then we're gonna just move on a little bit faster. So I'll tell you, this is another rare tachycardia that you can basically confuse with AV NRT. The reason being because you're going to go over your algorithm. You're going to say, okay, this is regular tachycardia. It's narrow complex. I either don't see a P wave, or even if I'm seeing it, it's like with a very, very short RP interval. So it could be AVNRT. But this is actually junctional tachycardia. It's rare, and it really what will happen with adenosine, it should not break, but it should slow down, and then you actually might even see an underlying sinus rhythm as an AV dissociation. But really, a lot of times it must be proven in the EP lab, and even in the EP lab, there's a confusion sometimes in terms of maneuvers, whether it's AVNRT or junctional tachycardia. But just something to be aware of. And just a couple of practice cases. I think we have like a couple of more minutes. Maybe we can just go through quickly. Whoever wants to give it a shot.
Who's going for it?
I can go.
All right.
So we have a narrow complex irregular rhythm.
Mm-hmm.
And let's see. It looks irregularly irregular.
Okay.
I don't see.
So tell me, what is your differential now, immediately, based on this information that you said? You're irregularly irregular, right?
So differentials would be AFib with RVR.
Okay.
Multifocal atrial tachycardia.
Okay.
Or what is it?
Sinus tachycardia.
Sinus tachycardia with premature atrial.
PACs, yeah,
Yeah.
with frequent PACs. Okay. So and then just basically exclusion criteria. So for multifocal atrial tachycardia, you need
P
three
waves.
different morphologies of P waves, right?
And I don't see that here. It's very difficult to see discernible P waves. I mean, if you look at the
and I can tell you that this is not an artifact. So
right. So yeah, I don't see discernible P waves on this. Yeah. So this is probably AFib with RVR.
Yeah. So AFib. That's it. So yeah. That's all it is. All right. Who's gonna do this one?
Can go again.
Okay.
Okay. So again, we have narrow complex tachycardia.
Mm-hmm.
It's regular, and I see. I really can't tell. So I see the P waves. I think it's 1-to-1, but I do see some PR prolongation. It's some irregularity actually.
So remember, let's see. So which leads are our best friends for P wave assessment?
Lead 2.
Okay, so let's look at it.
Don't really, yeah.
So there might
there are some.
So another question is: are you dealing with an organized or disorganized activity in the atrium?
I would say disorganized.
So I think you started off really nicely. You said it basically. Yeah, I kind of see something.
Yeah.
You were thinking about a P wave, but then you're also not as sold on the side of, oh, this is just AFib and so I think this one is a little bit tricky, and then it needs a little bit of training of your eye. So if you look at the lead 2, right? So this, then you have this, and you have something buried here, then you have this, and all these deflections are kind of connected by this slurred line. slurred line, right? So this would essentially be your atrial flutter, right? So you have, as the circuit goes, it kind of slows down a little bit in the, in the isthmus portion, and then depolarizes, and then again slows down, depolarizes. So that's that, and it's a really good thinking process. That's your like in between, right? You're not in your atrial tachycardia where you have a nice, anatomically nice P wave, but you're also not having atrial fibrillation where everything is just disordered.
Right.
So this would be
P waves are also a little bit more discernible in the V1, like a little bit more than V2.
yeah. So again, here you see this and this, and then if you apply the algorithm, it's going to be, I have more P's than QRSs, so your differential will be atrial flutter or atrial tachycardia. And then if you again apply your thinking process that you said, well, I don't think this is that organized to be an atrial tachycardia, you will reach the diagnosis of atrial flutter. That's it.
Got it.
All right. I think can we do more?
We can do one more.
One more. Who wants to do this one?
Joe is paying so much attention. Joe Elias, but you're not answering.
No, I don't think he hears.
Peter, want to try?
Yeah, how's it going? So yeah, I see, it looks like an irregular strip. See the P waves up in lead 2. Not really sure where to go from there after that.
So do you see anything that looks like a P wave? And good thing is you have lead 2 as a rhythm strip.
Yeah.
So you can kind of go slowly and see if there is anything that looks like a P wave.
Maybe some like slight P waves, but
What about this?
yeah.
Okay. What about this? Kind of looks like a P wave, yeah. And then you have this also. And maybe here a little bit. And then here also. And then this small one. So again, if you go by your differential diagnosis, you have AFib, you have multifocal atrial tachycardia, you have sinus. So the more, first of all, there is a P wave, so automatically rules out atrial fibrillation. Then you are left with these two. Sinus, would have a consistent P wave. You wouldn't see different morphologies. So this could either be, sinus with PACs, or it can be multifocal atrial tachycardia. And here, given the really multiple weird morphologies and a lot of irregularity, you can say this is a multifocal atrial tachycardia. And that's pretty much it, how you reach the diagnosis.